when we are deciding to go for IVF stimulation, we must have some idea whether this patient is going to be normal responder, hyper responder, or hypo responder. Now, how to know whether patient is going to be hyper responder? This patient has typically thin patient with low BMI. The AMH is more than 3.5 nanogram. They're having PCOS. If they have undergone IVF treatment previously, peak E2 level would be more than 3000 picogram. And if you go across the IVF details, normally more than 15 oocytes are retrieved at a single go. So these are the typical case of hyperresponder and which are likely to develop OHS. So you must be careful in deciding the dose, protocol, trigger, whether to freeze all, whether to transfer, what luteal support to be given, what trigger to be given. So all these things matters when there is a hyperresponder. Regarding poor responder, these are the patients who are likely to respond in a poor way. Those patients who have got age more than 40 years. This is Western data. So probably you can say in Indian data 36 years. The patient having diminished ovarian reserve. What are the criteria to assume that patient may be having diminished ovarian reserve? If her day 3 FSH is more than 9 international unit, day 3 E2 is more than 75 picogram, the AMH is less than 1.1 nanogram, and if you look at the antral follicle count, it is less than 6. These are the patients who are likely to respond in a poor manner. Many times, even though there is no diminished ovarian reserve, and if you observe the IVF cycle history, they might have prior cancelled cycle due to poor response. Now there are certain unrecognized a poor responder. You come across and you realize after stimulating only. So how do you know? Say after stimulation, if less than 6 mature follicles are developing, if you measure the peak estrogen level, it is less than 800 picogram. The whole cycle gonadotropin consumption keeps rising and it is reaching to more than 4000 units, and stimulation is lasting more than 12 days. The exception is PCOS. So these are the patient which confirms that this patient is going to be a poor responder. Now all across the world, till now, everybody had a different definition of the poor responder. So now more or less all are following Bologna criteria for poor responder. What is that? They have considered 3 criteria and at least 2 of them are present, then it should be considered as a poor responder. Even if there are no criteria present, still there are 2 episodes of poor ovarian response after conventional stimulation is enough to define the patient as poor responder. Now what are those criteria? The criteria number 1, the advanced maternal age, or any other risk factor for poor ovarian response like chemotherapy or maybe surgery on the ovaries. Criteria number two, documented poor ovarian response in previous cycle. And criteria number three, abnormal ovarian reserve test, which we have already described a couple of minutes back. Now, how do you decide? Which are the predictive factors for the assessment of correct stimulation protocol for IVF? What are those factors which you should consider while deciding a protocol as well as a starting dose of gonadotropin? One is age. As the age advances, the gonadotropin consumption increases, the follicles are more resistant to be stimulated. Second, baseline FSH, E2, LH, and AMH. Third, antral follicle count. Fourth, BMI. Fifth, whether there is a presence of PCOS or not. Sixth, is there any presence of pathology leading to pelvic adhesions like endometriosis, chronic pelvic inflammatory diseases? Seventh, is there any presence of any fibroid or not? So these are the factors to be considered when you decide a starting dose as well as the stimulation protocol. Now we will discuss about the agonist action. When you give agonist, the single injection binds with the receptor for about 12 hours. So whenever you are using a low dose or mini dose agonist, especially in mini fill protocol, we give injection 12 hourly. Agonist causes initial flare of pituitary. The effect on LH is more than FSH, and this flare lasts for 3 to 6 days. Following the flare, there is a down regulation of the pituitary. The effect is more on LH than FSH. The suppression continues after stopping agonist up to 9 days. And it has been noticed that complete recovery of pituitary from down regulation may take 6 weeks. The agonist effect, dose dependence effect, less on FSH than LH. If you are using agonist depot, it prolongs the down regulation, increases the gonadotropin requirement, and reduces the pregnancy rate by affecting embryo and luteal phase, provided you are transferring in fresh cycle. But depot injections indicated in IVF with severe endometriosis or commonly used before thaw frozen embryo transfer. The agonist can replace antagonist bound to GnRH receptors because of its strong affinity, and that is the reason why Agonist trigger can be used in antagonist protocol very easily and conveniently. What are the agonists available in the market? The commonest is leuprolide acetate, which is 1 milligram per ml, buserelin, that is 0.5 milligram. The equivalent dose of 1 milligram of leuprolide acetate is 0.5 milligram of buserelin, which is equivalent to triptorelin 0.1 milligram. There is no one is better than other. The effect of down regulations more or less are same. So it's a matter of availability and convenience which agonist preparation you want to use. Now talking about antagonist action. The antagonist cause quick reversible suppression of the pituitary within 8 hours. The biological half-life is around 20 hours. So after that, LH can rise. So whenever you are using antagonist, especially near trigger days, you have to be very careful. If the last dose of antagonist and trigger is more than 20 hours or around 20 hours, it is better to repeat the antagonist before trigger. The antagonist effect is more on LH. If E2 is less than 300 picogram, the onset of the antagonist can be delayed without any compromise in the results. So because there are few protocols who combines mini flare and antagonist together because they want to take the advantage of initial flare effect of the agonist, then they stop agonist, they continue with the stimulation and they start antagonist little late. Undue delay can reduce the pregnancy and early start may increase a gonadotropin requirement. So whenever you are in doubt or dilemma, better to start antagonist earlier. There is no disadvantage except it increases the gonadotropin requirement. In many of the center, when they start antagonist, they increase the dose of gonadotropin stimulation which was going on. The studies have proved and concluded that there is no need to increase the dose of gonadotropin after starting antagonist. Now, before starting the cycle, the proper down regulation should be there. Then and then you can expect a symmetrical and proper follicular growth. So what are those criteria of down regulation? If the E2 is less than 30 picogram, LH is less than 2 international unit, progesterone less than 1.2 nanogram, there is no follicle which is larger than 10 millimeter in any of the ovary, and endometrial thickness is less than 5 millimeter. These are the criteria of down regulation. Suppose E2 is more than 30, up to 50 is acceptable still, but if it is more than that, then chances are there that some activity is going on in ovary, and maybe commonly it is because of the some small cyst in the ovary. We will discuss separately what is to be done in such scenario. The LH level should not be less than 1 international unit. If it is less than 1 international unit, then you must include a significant LH activity right from the beginning in stimulation. The progesterone less than 1.2 nanogram, if it is more than that, really what to do when the progesterone level is high in early follicular phase. Lot of things tried, but there is no significant advantage, and it has been now proved that the progesterone, fluctuating progesterone level or maybe early progesterone level, can derange the endometrial receptivity. It can advance the endometrium, but effect on the folliculogenesis is little less remarked. So whenever there is progesterone level is high, you might delay the stimulation. You might try giving antagonist for a day or two, and then you start stimulation. But overall, it affects pregnancy a little bit. Now, is there any other way how to predict a ovarian response? Very recently, article has shown that if you observe the response, ovarian response, by difference in the E2 level before and 24 hours after the drugs in progesterone pre-treatment cycle, you can make out the response. Like suppose if you give exogenous FSH 300 or luprolide 1 milligram or triptorelin 0.1 milligram. You have to measure E2 level before injection and after 24 hours of injection. In case of exogenous FSH, if the difference is more than 30 picogram, in case of luprolide, the difference is more than 20 picogram, and in case of triptorelin, the difference is more than 5 picogram. It is suggestive of good ovarian response. Now coming to antagonist cycle, when the baseline FSH, especially in poor responder, when it is more than 8, it is not ideal to start antagonist protocol. So this patient requires either estrogen or OC pills pre-treatment, and better to bring down basal FSH less than 8. Then and then you can have a better response, especially with antagonist cycle and poor responder. Next time we will continue discussing IVF protocol. Thank you.